Comorale. My name is Stanley Mickey. I'm the intern program manager for the Family Health Unit. This project is maintaining essential MCH services during health emergency. JICA project for Pacific co-learning toward resilient health systems in the FSM. The outline of this presentation is the background, definition of the health emergency, governance and coordination, modification of service delivery during health emergency, prioritize essential MCH services during health emergencies, human resource capacity during health emergency, utilization of digital technology, and summary. Background: the COVID-19 pandemic occurred in 2020. The number of patients increased in FSM in 2022. While FSM managed the control of the COVID-19 pandemic, many essential services such as MCH services were disrupted during this period. The main challenges identified during the period are lack of manpower, shift of healthcare priorities to infectious control, lack of awareness, and low self-care capacity in the community. The lesson learned from the period provide an opportunity to build a more resilient health system preparing for the next emergency, to ensure the continuum of essential services during a non-emergency and emergency periods. Definition of health emergency: a type of event or imminent threat that causes or has the potential to cause a range of health consequences and requires coordinated action, usually urgent and often non-routine. A public health emergency may pose a substantial risk of significant morbidity or mortality in a community. The system is prone to natural disasters. When a health emergency occurs, prevention, mitigation, preparedness, response, and recovery. Prevention is to protect from disasters so that they never happen. Mitigation, to decrease or eliminate the impact of disaster risks which are not preventable. Preparedness, action that result in person knowing what to do and how to respond after the disaster occurs. Components include planning, monitoring, and warning. Response, activities to minimize loss of life and damage, to organize the temporary removal of people and property from the threat. Recovery, activities that are directed to restore normal function and operations. This phase may last for a considerable time after the disaster. These are the pandemic phases: inter-pandemic period, pandemic alert period, and pandemic period, post-pandemic period. Phase 1, no new influenza virus detected in humans. If a new influenza virus presents in animals, the risk of human infection is considered to be low. Phase 2, no human infection, but a circulating animal influenza virus poses a risk to humans. Phase 3, human infections with the new virus, but no or very frequent human-to-human spread. Phase 4, small clusters with limited human-to-human transmission, but spread is highly localized. Phase 5, large clusters, but human-to-human spread still localized. Phase 6, increase and sustain transmission in general population. Post-pandemic period, influenza disease activity will have returned to level normally seen for seasonal influenza. Timing of activating modification plan during emergency. Phase 3, pandemic alert period of WHO pandemic phases and emergency declaration. This is an emergency operations center state. It's like a chain of comments. Governance and coordination. Designate a focal point. It is recommended that the Chief of Public Health take responsibility for ensuring essential health services, MCH, NCD, and CDs at the Public Health in collaboration with the Emergency Operations Center. Under the Chief of Public Health, the MCH coordinator will be the focal point for MCH services in health emergencies. Governance and coordination, responsibilities of the MCH coordinator during the disaster. Support the lead coordinator. Procurement of reference materials and consumables. Strategies for MCH services, including MIS implementation. Provide technical assistance with MCH services, including MIS in health emergencies. Liaise with other clusters and sectors, and partnering with disaster management, civil society organization, private sectors, and etc. Modification of services delivery during health emergency. The Division of Primary Health Care, Public Health, to plan in collaboration with POC. Allocation of personnel. Laboratory tests, examinations, and immunizations. Equipment procurement immediately after establishment. Timing of decentralization or outreach. Prioritize essential MCH services in health emergencies. 1. Priority MCH services during health emergencies. To antenatal care, ensure 4 to 8 or more visits. Postnatal care, ensure 1 visit at 2 weeks postpartum. Priority groups, first and second antenatal care visits. Antenatal care during late pregnancy for low-risk pregnant women. High-risk pregnant women. The obstetrician will determine the schedule of antenatal visits. Prioritize essential MCH services in health emergencies. Scope of care. Include all non-emergencies examinations, laboratory tests, and health education for mothers. Health education should continue during health emergencies to support mothers' self-care, provided verbally or through IEC materials, paper, or online. Promote breastfeeding and concurrent care. Delivery assistance. Childbirth is assisted in state hospital. In outer island, dispensaries will assist delivery. Immunization. Routine immunizations for infants continue through outreach or at Pohnpei immunization clinics. Services considered to be suspended. The following proactive screening services will be suspended in health emergencies: breast cancer screening and dental screening. These are the type of services that's provided during the health emergencies. Family planning counseling services, including contraception, antenatal care services, minimum of 4 face-to-face visits, blood taking, first antenatal care, second antenatal care, tetanus vaccination for 28 weeks, prospective mothers provided with adequate stock of iron, folate, calcium, deworming pills, delivery in presence of a skilled birth attendant, promotion, protection, and support of exclusive breastfeeding for 6 months. both states of Pohnpei and Chuuk. Non-emergency period for public health and dispensary. Emergency period for public health and dispensary in Pohnpei. An emergency period for public health and dispensaries in Chuuk State. The same services for postpartum, minimum of first visit, postpartum care of sick neonate, nutrition lifestyle counseling for prospective and current mothers, detection and treatment of severe acute malnutrition in infants, micronutrient supplementation, vitamin A, albendazole, iron folic acid, and F75, F100 Rosamond. Prevention and management of childhood illness including pneumonia, meningitis, and diarrhea. Rheumatic heart disease screening and treatment. Oral health in children. Breast cancer screening. Clinical examination. Both state non-emergency period in public health and dispensaries in Pohnpei State and Chuuk State. If you're looking at this chart, those that check in the boxes, those are the services that were provided. And those that were not checked, those are the services were suspended during this emergency. Collaboration with other organizations. Human resources for health are extremely limited during the health emergency. Therefore, intersectoral cooperation is crucial during health emergencies. Task sharing between public health, hospital, and MCH. Utilization of community volunteer, UCVs. Collaboration with other NGOs, such as Red Cross and Women Council. Utilization of digital technology. Reliable internet and power source, generator, solar, are essential for outer islands equipment use. Telemedicine and teleconsultation increase the accessibility of healthcare in remote settings during non-emergency. Health education messages are shared via radio, online consultations, and social media. Mobile ultrasound devices help screening for detecting high-risk group in outer island and remote area. In summary, even though infectious pandemics and natural disasters can significantly impact the health system, maintaining essential MCH services during health emergencies is important because MCH supporters should liaise with other clusters or sectors. Cross-training and staff rotation during the normal periods ensures staff familiarity with multiple programs for emergency response is required. Thank you for listening.